Hey, everybody. This is your brand new episode of Tell Me I'm a Good Mom. I am so excited for today's episode. It's our IVF episode, and I get asked about my fertility journey all the time because I have gone through IVF and I have gone through it pretty publicly. I've shared a lot of my experience dating back to 2020 when I did my very first egg retrieval. And we have the expert of experts on the show today. I am so excited to have my very own fertility doctor on today's episode. Please welcome with me in your car, in your living room, at the gym. Please welcome Dr. Sheeva Talebian, reproductive endocrinologist and the director of third-party reproduction at CCRM Fertility of New York. She is just a banging doctor, you guys. She's the recipient of several surgical and teaching awards. She's experienced in surrogacy and egg donation, same-sex reproduction. And I have you to thank for my daughter. Welcome.
Thank you so much for having me. It's really an honor to be here to speak about something that's obviously near and dear to my heart.
Of course. I have known you since 2020. And it's 2026 now. So let me just ask you out of the gate. Is like that length of time that you know patients and interface with patients typical? I've met you in 2020.
Right. So I would say that that is now becoming more commonplace because women are coming in the planning phases and in the sort of let's talk about fertility preservation phases. So I'm getting to meet women there where they're maybe preserving fertility. And then I've been around long enough where thankfully I'm still here, still working, still with you all.
Yeah.
And I get to see you on the other side of it when, you know, you're ready to actually start your family. So, so it's becoming more common.
More typical.
Yeah.
So what did draw you to fertility medicine? Like, were you doctoring in a different field before you went to fertility medicine, or has this always been your path and your passion?
So
doctoring in a different field.
Yeah.
I don't even know how you say that.
No, but so we first train as general OBGYNs and then choose to specialize or not. And so it was during my residency that I had exposure to the field and chose to specialize in it. Of note, my father was an OBGYN, so I knew what that was. I was exposed to women's health my whole life.
Yeah.
And what drew me specifically to the fertility, I think, is actually what we just touched on. It's that relationship and that journey. And I wanted to be a part of a field where I got to know people for a period of time and an actual very intimate, point of their life, very vulnerable point of their life. So I wanted that aspect of medicine, but I also liked the surgical aspect of it and the science of it as well.
Yeah, she's a surgeon, y'all. She has surgeried me a couple of times. I'm curious. So how long has your career been in fertility medicine now?
Right. So OBGYN residency from 2001 to 2005, and then a fellowship in reproductive endocrinology and infertility from 2005 to 2008. So I finished that in 2008 and then officially get to practice fertility medicine in 2008 onwards.
So I always am curious with people that have very meaningful careers. How has your perspective on your field and your expertise changed from when you entered the field to where you're at now?
Right. So and again, I have that historical length of time to talk about it. I would say.
And you've really seen the fertility, what do we call it? The fertility field of medicine. I mean, it's also an industry, right? Like you can think about it in so many different ways.
Right. So what I would say is the biggest change is that when I first started practicing in 2008, 95% of the people who came to see me were actively trying to get pregnant, not getting pregnant, or having miscarriages. And a very small portion were coming in to discuss fertility preservation. And that's mostly because egg freezing and embryo freezing at the time wasn't as strong and successful as it is now. And now I would say 50% of my day are people coming in who are not actively trying to conceive, but are discussing fertility preservation and family planning. So I would say that's the biggest change over the course of time. And that's because our freeze technology, both eggs and embryos, now are highly successful compared to 2008.
Yeah. And that, to your point, is reflective of my own fertility journey. Fertility journey.
I don't like to
journey.
call it infertility. I think we're sort of, it's your fertility journey, your fertility path, right?
Yeah, absolutely. So today's episode, I think, is going to be a good one. Like I said, I have shared parts of my story with my following, and this is one of the topics where I get the most feedback, questions, requests for guidance. It is a hot topic. And I think as TikTok has grown and Instagram has grown and changed, it's like it's just going to continue to be like on I don't know, top of mind for anybody who is getting pregnant, even if like you have no issues getting pregnant. I feel like people are so much more exposed to this type of education and information now, for better and for worse. And so I want to jump into IVF, egg freezing, all the stuff. I wanted to do the introduction, but I want the bulk of the episode to be fertility 101 to a certain degree, because I see a lot of the same questions over and over again. So the first request is, can you explain IVF in a way that doesn't make me panic? Is what the first person asks.
So IVF, first of all, has been around since the 90s, right? We've definitely improved the way we do it. It's safer, it's more effective now. So what is IVF? So taking a step back. So every month within our ovaries, we have multiple eggs that are hanging out. They're immature.
Hanging out.
They're hanging out every menstrual cycle. They're hanging out and they're immature. In a natural menstrual cycle, our brain makes a hormone called FSH that travels from our pituitary gland to our ovary and tells one of those eggs to develop and ovulate. So every menstrual cycle, you have multiple eggs hanging out, but only one actually gets used.
How does the body choose?
That's a great question. We don't know why that one egg is chosen over others. I wish the body was smart enough to know that that was actually the good egg. That was going to be the one that had a healthy chromosomal backbone, but it's not, right? Because if it was, then, you know, in theory, we'd be more fertile naturally, right? So there's a handful of eggs that are hanging out. And so what IVF is, and it's egg freezing, is the same process. We stimulate the ovaries so that all of those immature eggs that are hanging out mature. And so that's what the injections are that women take when they do this. So they're taking injections, FSH and LH. So our brain makes a teeny tiny dose of these signaling hormones to tell one egg that lives within one follicle to grow every month. And for this process, we want all of those follicles, which hold the eggs that are hanging out, to grow. And so that's what the shots are that women take. And they're generally on them for about 10 to 12 days. And so we're controlling the growth. And then eventually in the end, they take a trigger shot, which gets those eggs to ovulate. But before they release from the ovaries, we extract them. So taking a step back, so we're getting these eggs are hanging out. Only one actually gets utilized, but we're trying to utilize all of them, as many of them as possible. And then this is where things diverge. If the plan is just to freeze the eggs, if the eggs are mature, they get frozen in the lab. If the plan is to fertilize, we have sperm on hand. And for every mature egg that we are able to obtain, we put one sperm into the egg. And the next day we see if it fertilizes. But it's just
so that's the path of like egg freezing or IVF creating embryos.
Exactly.
So the setup and the medicine and the injections and the schedule are the same up until, I guess, the point where the eggs have been extracted from the body. And then it's like, okay, path A or path B.
Exactly.
Okay.
But up until that point, the stimulation process, drugs, protocols are, based on the woman's age, her follicle count, a blood test that we do called AMH. But on that front end, it's the same process.
Okay, Got it. I did 3 egg retrievals. Yes, I did 3 egg retrievals. 2020, then another one in the middle of COVID, and then the last one. And then we did the IVF based on that last one. So, and then do you remember? I don't know if you remember, but I certainly do. I had my endo excision surgery, which I want to talk about later down the line on this episode. But then why is it that I had to do, and I don't know if you recall, I had to do more injections before my frozen embryo transfer? Do you remember that? I had gone from my endo excision surgery, and then I had to stop taking birth control because the birth control like quieted my ovaries for the surgery
Right.
so that they wouldn't get like accidentally chopped while the doctor was in there.
Right.
And then for me in my protocol, I had to do more injections before we did the transfer. Do
Right.
you remember that?
Yes. So
do you remember why?
Yeah. So, okay. So let's say we have these embryos frozen. So nowadays at most clinics, I would say at sort of the top clinics around the country, we typically, when we make the embryos, we chromosomally screen them, which entails freezing them. So many women undergo what we call an FET, frozen embryo transfer protocol. And there's several different protocols. There's medicated, where the woman is on all synthetic estrogen and then progesterone, and then we thaw the embryo and implant, so she is not naturally ovulating on her own. And then there's more natural protocols. And for you, we wanted to do a more natural protocol. Just thought that would be more successful, especially given a history of endometriosis. And just less synthetic hormones. So I think we started with a medication called letrozole, which is going to tell your brain to tell your ovary to ovulate.
Mm-hmm.
Your ovaries were a little suppressed because you had been on pills for a while. So we added a couple days of injections at the end. But the whole protocol was basically your brain was telling your ovary to make a couple follicles and make natural estrogen. And then those eggs ovulated. And then we synced the embryo thaw to what your natural window would be, which is roughly 6 days after an ovulation.
Mm-hmm.
That's when an embryo naturally implants in the body. Egg and sperm meet together in your fallopian tube. That embryo divides for almost 6 days before it enters the uterus.
I'm coming back to the
Yes.
to the injections now. Oh my God, it's so traumatic to be on like day whatever of your injections, and you're just trying to get to this goal, whatever stage you're at, whether it's egg freezing or okay, now I'm making embryos, or oh my God, I have my transfer coming up. It is emotionally exhausting, and I know that you see this every single day in your practice with patients because you see your patients a lot in these cycles. And I think that the emotional experience of it is probably the most challenging aspect of it. And I'm curious what you say to your patients, or like how you provide them guidance through that specific part of the process, because it is really challenging.
Right. So I think the most difficult part of fertility medicine is still the lack of control and not knowing how that one specific cycle is going to end. Right.
Yes,
Because
the unknown.
it's the unknown. Unfortunately, it's never 100% that you're going to get great embryos. And it's not 100% that each embryo is going to stick and grow the whole way.
Mhm.
So, I mean, and even taking it a step earlier, the anxiety that some of my patients have just coming in day one, maybe they haven't even tried to get pregnant and they want to come in and understand their fertility. And they're just so anxious because I get this a lot. I'm afraid you're going to tell me something bad. And, what I say is, listen, there's no bad here. Like, we're learning, we're going to learn about your ovaries. We're going to learn about your follicle count. We're going to learn about your AMH. And then we're going to talk about it. And we're going to act on whatever information that we get.
Mhm.
So, but I think it's that really the lack of control, right? And many things in our lives, like you have an exam to study for, you just study really hard, usually translates over to good results.
Yeah.
You want to train for a marathon, you train really hard, usually translates over to good
You're
results.
a marathon runner.
And a lot of like my analogies are to that running,
Yeah.
right? It's, but I think for this, it's one of those things that you could do everything perfectly perfect, take all the right supplements, eat all organic, low stress, meditate, and it doesn't necessarily mean that we're going to achieve success at the first shot, right? So,
Yeah. It's the not knowing when it's going to end, not knowing the outcome. Now it's coming back to me. That is really the most challenging because, yeah, with all of my egg freezing cycles or whatever, my ovaries were always like slow to respond to the medication. So I always had to go like 3 to 5 days longer than I think the typical
right.
individual. So you like have a frame of mind on like how long you should be doing the treatment for based off of other people's experience. It's like, oh, 11 days of shots or 12 days of shots or
Right.
whatever. And I would be on day 17.
Right.
Just feeling so flattened by the experience. But ultimately, you get there, you get to the other side. It is an emotional marathon,
Right.
for sure. But everyone does eventually cross to the other
Right.
side.
Right.
Just like with pregnancy, like
Right.
this child has to come out of my body at some point soon. I'm curious, when do you recommend IVF? And I guess I want to talk about IVF specifically, not even egg freezing in
Right.
this instance, because I'm very similar to kind of the person that you just mentioned, right? Like, I'm concerned about my fertility. I'm 33 years old. I want to do egg freezing because I think it's important. I'm not in a relationship, or I am in a relationship. I was not in a relationship. I'd been single for a while. And I was concerned that maybe I would never meet somebody, and I wanted to be prepared. But in what instance do you actually recommend IVF?
Right. So, I think if you don't have a partner, right, there is the option to, start a family with anonymous donor sperm and make embryos, right? So that is an option, but that's not typically something I introduce. Like, that's typically the woman may say, I'm single, but I'm ready to pursue this on my own.
Mhm.
And then we talk about it, right? But egg freezing now is an option. Again, it was experimental until 2012, and it's gotten, increasingly, improved technology. So, but to do the actual IVF, so that it just depends. So sometimes, obviously, if you've been trying to get pregnant and you're not getting pregnant, we are going to go straight through. We're not going to necessarily freeze eggs first, unless there's some
How
scenario
long?
where you would freeze eggs first, right?
Yeah. How long should somebody be trying to get pregnant and not be getting pregnant before they go to IVF?
Right. So, well, technically, the textbooks, call infertility. If you're under 35, they give you a full year of trying. 35 to 40, they give you about 6 months of trying, and after 40, they're like after a couple months. But that's just like the definition.
Okay.
And it just depends. I may have an under 35, and we base it a lot on the woman's age because we're born with our eggs. Our egg quality and quantity just shifts over time. So a lot of the treatment guidelines are more based on female age than male age. But if you're under 35 and you've really been trying for a handful of months, most people don't wait a full year before they come in. Many come in sooner, and I 100% agree, because especially nowadays, there's a lot of, information they get on their own, educating themselves. They know they're having, ovulating, they're timing it correctly. If you're really not pregnant most people after 6 months get frustrated and come in, and we do the testing. And that the testing takes another month or two, right, to get all that information depending on where you are in your cycle. And then the decision to go, it depends on what the testing shows, right? And there's really only a couple buckets of treatment. If you're not ovulating, there's pills that we could give you to get you to ovulate, and then you have intercourse. There's IUI, which stands for intrauterine insemination, and that's putting the sperm at the top of the uterus when the woman's ovulating.
You just put the sperms inside?
Yeah, exactly. You just put them in to the top of the uterus when you're ovulating, so just getting it closer.
Okay.
And then there's the IVF, right? So I would say over the past probably 5-6 years, we're going to IVF more quickly because it is more successful. We chromosomally screen the embryos. We only put in one at a time. So the risk of twins and triplets is much, much lower now than it was 15 years ago. And when you do the IVF, you're freezing the embryos. So it does allow you to preserve some fertility for the future if you haven't already kept eggs aside.
Yeah. That's really helpful. In my experience, I think I had been your patient long enough and you had been able to kind of understand my medical history over time. And we went straight to IVF, but it wasn't until you did a ton of testing and like double clicks
Right.
and digging deeper for me personally in my situation that we came to that conclusion. Right. In fact, and I have, talked about this, but I think it's relevant to tell the story again. When I first came to see you for that very first time, my AMH was low. I think it was like under 0.5, and I was 33 at the time. And I remember I was confused how that could happen, and I think you were confused also, but not shocked. Like,
Right.
You're a fertility doctor. You see all kinds of stuff. And we had like an okay outcome. I think I got 8 or 9 eggs from that first retrieval. And then my second retrieval didn't go great. And then my third retrieval, when I was 38, actually went okay, but I had put a ton of prep into
Right.
it. And at which point along my journey did you start to suspect that I had endometriosis? Because you said to me, Lauren, before I even implant one embryo inside of you, like, I need to make sure that you are not dealing with XYZ.
Right.
And the reason I think that this story is relevant is because I so often see people on the internet talking about their IVF journey, their failed implantations. And I'm so curious, why is it in my case, I was lucky enough, well, to have a great doctor, but to not be shoved right into a frozen embryo transfer process out of the gate, and why you instead sent me down this alternate path to try to identify and deal with potential barriers. Because I don't think a lot of women are getting that kind of care.
Right.
I think they're being shoved right into a transfer attempt, and like other things in their health history are being overlooked potentially for whatever reason. And like, can you talk about that a little bit?
I'll say this is something that the deeper I've gotten into my career and I'm seeing that IVF isn't always the answer by itself. So that's one piece of it. And
Okay, that makes sense.
do also think that also over the course of time, endometriosis is not one specific disease. Historically, the teaching was very bad pelvic pain, blocked tubes, IVF's the answer. And I now think of it more when I have younger patients, who are not getting pregnant, lower AMH at a younger age.
Sorry, I keep
is
saying
another
that.
like potential tip off.
Yeah, it was the low AMH.
Yeah, so lower AMH. And then when I have patients who are now getting into their later 30s, and yes, knock on wood, thank God, we do have biologic embryos, but, several, maybe not
10.
10.
Does anyone have 10 embryos just frozen on the shelf?
Not typically, but sometimes yes, but that's pretty rare. That's pretty rare, right? That's rare. But again, as we're getting deeper into our 30s, we know that it's going to be harder to make these biologic embryos. So when we have a set number and then we say, okay, well, ideally, how many children do you want? And, most, I would say 2, usually most say 2. So then I say, okay, we could go ahead and do your transfer, but if it doesn't work, like these are some of the reasons why. And then, it is over the course of time, I get to know my patient and some of the subtle symptoms of endo. A lot of GI complaints, bloating, like moodiness, like like other symptoms. It's like GI symptoms, like urinary symptoms, joint pain, body pain, back pain.
Like,
yeah, a lot of back pain. There are a lot of signs of endometriosis. And so if you have other symptoms, we have a limited number of embryos. We could either start that process, but if you're not getting pregnant, then we're going to have to deal with it. And so it's, I don't test everyone for this, but if there's some degree of suspicion and we know that getting embryos is not going to be so easy moving forward in time, then deal with it now.
What would you say to people who suspect they have some type of underlying health condition, they haven't gotten pregnant, maybe a transfer tube failed, and the doctor keeps sending them down the path of we're just going to keep trying?
Right.
Like, what would you say to those people? Or what would you recommend?
Right. So again, doing the same thing over and over again typically leads to the same outcome, right? So when I personally with my patients, if you have a negative transfer, I try to do some testing. I try to tweak the protocol. I try to do something different before we jump in again. Because could it just be bad luck with that embryo? Could be, but there's also a reason why you're there, right? If there's been all this infertility lead up and now you're failing transfers of good quality embryos that are chromosomally screened, that's a tip-off question mark. This is more than just making the embryo. There's something else going on, right? And so for those patients, around the country that feel like they're just kind of doing the same thing over and over again, I would ask your doctor about, could it be something else? Is there any other testing that I haven't done? And, or go get another opinion if you feel like you're just kind of doing the same thing over and over again and nothing's changing and it's not giving you success.
Sure. Okay. That's helpful. Can we talk honestly about how many eggs you should get in a retrieval? How many embryos is normal? How many PGTA embryos is normal? Because I think that, and again, I realize that the answer is different for everybody.
Right.
But I think that it's hard for people to get straight, realistic answers on this. And it's always like, oh, the probability is this, right? The probability is this. And I know that you can't answer because like we don't have like an actual patient in front of us with specific health information where you can like analyze. But I think the reason I'm asking is I know a lot of people who are around my age who have done one frozen egg retrieval or egg retrieval. They're like, oh, I have like 14 eggs. I'm going to be fine. And I know from personal experience how quickly the numbers can shrink to almost nothing. And so can you give us like a really brutally honest, not in an attempt to fearmonger any listeners, but if you are on this like fertility journey and this is your path, can you give us like a real POV on what the numbers look like and like what you need
I think
these scenarios?
What this highlights, one of the biggest problems of fertility medicine are limited diagnostic tools, right?
Yes.
Like my ability to scan, image, blood test you and say, okay, according to the testing, you specifically at age 30 need 8 eggs to give us 2 good embryos and one of those will work, right? So we don't have that level of diagnostics. So a lot of this stuff is very generalized. And to be honest, we're learning because the data on egg freezing is now starting to come out because a lot of the women who started to freeze their eggs at a point when the technology was good are just coming back to use them. And I would, again, for someone who has normal testing, no infertility history, so they're not trying to get pregnant yet, I would say roughly in a 30-year-old freezing eggs, ideally I would say 8 to 10 frozen to give us hopefully a 70% chance of a 1 live birth on the other side of that, around 8 to 10 at 30. By 35, maybe more like 15-ish. And then, late 30s, I would say, 20 eggs. And, by 40 onwards, if you're freezing at that age, you really need well over 20 eggs to try to give you 1 pregnancy on the other side. Those are general rough numbers, right? And that's someone who's coming in just to freeze eggs. They haven't tried to get pregnant before.
Yeah.
It's a different story. Someone who's been trying for a year and, maybe failed 1 or 2 IUIs or even didn't do IUI and goes to IVF, that's a different, and they're going into IVF and they want to know, okay, well, how many embryos should I get with one cycle? And it really depends on your age and how long you've been trying. Unfortunately, if you're really over 37, over 38, and you've been trying for more than 6, 8 months, like if we do one round of IVF and we get one embryo in the end, that's great. Anything more than that's a bonus. And I know patients are so, they may start out with 10 embryos, but only, 3 grow and only 1 tests good. And they're like, how is that possible? And again, if you're in your late 30s and you've been trying for a while, like that's why you're doing the IVF. Unfortunately, like our bodies are not that efficient.
Yeah, it can be pretty shocking
Yeah.
when you live through the actual experience of seeing your numbers drop every single day. And at the end, like maybe you're left with 2 or maybe you're left with nothing.
Sometimes nothing.
Sometimes
Exactly.
nothing.
Sometimes nothing. And it's
Yeah.
really, I can only imagine after the weeks of shots and everything. It's really, it's very hard news for me to deliver.
Yeah.
And I'm sure it's very, very devastating. But again, we always, before jumping into another round, that's where we talk about, okay, what like lifestyle stuff, vitamins, supplements, like.
That's what I want to talk about now. So I started prepping my body for my 3rd egg retrieval and IVF a year before we did the retrieval. And I am somebody that loves peptides. That's like, I have to change my lifestyle, all this stuff. And we actually were DMing a few months ago because I think you saw a piece of content that made you unhappy about some supplement or something. And you were like, I would really like to talk about this because I see it actually benefiting people in my practice. And I'm curious if you can touch a little bit on the stuff that is even anecdotal, but that you see working for women to improve their fertility outcomes.
Right.
Because what I did, which was NAD injections, glutathione, a year of acupuncture, pretty dramatic lifestyle changes, way fewer martinis, everybody, eventually got me to a pretty good retrieval at age 38. And our best embryo round that we had done, I don't even know what you call that, but like I got the most good embryos from my 38-year-old retrieval versus 33 and 35.
Right. And so I will say, I think a lot of the teaching for Western trained fertility doctors is, it is what it is. You're born with those eggs. They're exposed to everything they're exposed to. You could try to eat a little better. You could try to take some supplements. But if your egg quality is down, it's down. And there's no going back. There's no reversing that.
There's no going back.
I think that is a lot of the teaching, and that is a lot of the mentality of a lot of fertility doctors.
Yeah.
Or some, I should say. But I do say again, as I've been practicing and seeing over the course of years, I do think that lifestyle changes that lower inflammation in your body, right? So diet, exercise, lowering inflammation. I think improving.
Can I ask you, before you go on, what the fuck is inflammation?
Right. Yeah. Like
what is inflammation?
So inflammation is like your autoimmune system is revved up it's reacting, and there's a lot of microscopic proteins and factors that your body is secreting that is negatively affecting those cells.
Okay.
Right.
So that could be happening because of lifestyle choices, certain food choices, whatever.
Right. Interacting with our genetics and our environment, right? Why are some people more prone to inflammation and inflammatory symptoms than others, right? There's genetic stuff. Endometriosis is a pro-inflammatory condition, right?
Yeah.
So, and again, this is where the interplay of genetics, environment, right, and our lifestyle choices. But I will say that I have seen some patients where we do a cycle, outcomes poor. Maybe now I'm pressing deeply about diet, lifestyle, and they're drinking diet sodas, their nutrition. I assume we live in New York. Most people have good nutrition. Like there's a lot of good options out there. But then you press, and sometimes, their sleep quality is poor. They're drinking diet sodas. They're not taking really consistently their vitamins or supplements. They're not really eating good meals, whole foods, right? Like fresh foods, vegetables. And then we were like, okay, well, that's an easy fix, right? Like,
so you're saying that stuff actually matters?
absolutely, it matters. It matters.
Eat your apple a day.
It matters. Get good sleep, proper nutrition, try to eat whole foods. Absolutely, it matters. If it's all of that, well, it's going to help your skin, your hair, your brain, your muscles, right? It's going to help your reproductive organs as well. And same thing for men. Same thing for men. They got a free pass for a very long time, but
more though.
We're learning, right?
Yeah.
We're learning, right? That the smoking, the drinking, the THC use, it's bad.
Yeah.
Right? They could stop and 3 months later, it's a fresh batch. So, right? So I do think that I have seen people completely clean up lifestyle and have improved outcomes. Supplements. So big one, let's talk about NAD.
Mm-hmm.
It is something that I was turned on to. So personally, was taking it for other reasons, longevity world, like menopausal symptoms, etc., muscle recovery, and started taking it with some of my friends and my peer group. We're all early 50s. And just seeing like improved energy, recovery from my marathon training. So I sort of just started using it.
Mm-hmm.
I had this is like maybe 2-3 years ago, I had a couple patients who were over 38, had done some cycles, done several cycles, and each of them had an outlier cycle of just improved embryo quality and higher chromosomally correct embryos. And I was like asking them, what did you do? And they had both done NAD. They didn't tell me, just one did it, like had access to it through a friend and was doing it just from like a longevity clinic. And so that kind of turned me on to it. And then I started mentioning it casually to other patients who were, I would say kind of 37 plus or 35 plus, 37 plus, and just not doing great with their cycles, maybe one embryo, no embryo. And I just started mentioning it. Hey, listen, like you could try this. No one knows oral form, injection form, drip form, but but you could try it. And then I had another patient who came to me, and she was saying that on some of her Facebook groups that she's in for fertility, patients around the country were talking about it. Anecdotally, people were noticing improved outcomes, starting to look at the data. And I will say that it is looking potentially promising, that there might be some improved outcomes for some patients in terms of blastocyst yield, and healthy blasts.
Yeah.
But again, with that said, what are the risks? Pretty low risk if you have a cancer history, maybe questionable if you should use it. But people feel better overall on it. So I'm like, okay, if it's not harmful and it may have other benefits,
why not give it a try? Yeah, I think for me, it was a combination of, lifestyle improvements, but I had been taking NAD for a while before that transfer. And
And before that IVF.
Before that IVF, yeah. And I mean, maybe I'm part of that patient cohort of yours that had that outlier cycle, that was good.
Right.
So we can't say definitively.
But it is something we are studying more.
And you feel comfortable saying to
systematically.
patients, hey, this is something that you can try.
You could try it. What are the risks? Maybe if there's a cancer history, there is an out-of-pocket cost to it.
Yeah,
it's come down a little bit, I would say, in price because it's becoming a little more utilized. And again, most people who are doing the NAD are also doing other things, right? They're doing some other supplements like CoQ10, glutathione. Many are also doing acupuncture that's for fertility based. So there's this whole other world of things that you can add in, if you're not having optimal outcomes.
Okay. Super helpful information. The next questions I wanted to turn into sort of like myth prompts because these are things that I see over and over again commentary, just stuff that I'm constantly seeing, in the fertility conversation. So I'm going to say something, and you can agree or disagree, or give me your POV on it. The first, all fertility clinics are good.
So I will say,
or they're all created equal.
all fertility clinics are not created equal. Your doctor is important, but honestly, more important than your doctor is the quality of that lab.
The lab.
The lab is, I think,
where they're making the embryos.
The people that are freezing the eggs, the people that are fertilizing those eggs and making embryos, freezing, thawing. That is what varies the most from place to place. And everyone has their special sauce. The way I say it's like you could give 8 people the same recipe to bake a cake, and all 8 will bake it, and one's cake might taste a little bit better, right? So it really does come down to lab quality. And, thankfully in the US, we've got good options.
Yeah. How do people do their homework on that?
Right.
Because there's a lot of options out there. The very first time that I went to a fertility clinic, I got sucked into Kindbody, the private equity world of fertility, and I had a absolutely horrific experience there. But it's easy, in this day and age, to be like, oh, that pretty place on the corner of my block.
Right.
How do you assess what's a good lab and what's a bad lab?
So there's a couple sites like the CDC and Society of Assisted Reproductive Technologies has a site where you report your data. It's a little tricky though to look at that data because historically the data was collected in a way that was based on fresh IVF, where you extract, you fertilize, and you immediately implant embryos. That's really becoming, I would say, less utilized. And this concept of extracting, going the whole way through, testing the embryo and freezing it, and later implanting. And so it gets a little tricky to really report that data in a clear, concise way. But that is the CDC and SART sites are just a starting point. Other things to look at is, how long has that center been around? How long have they been freezing eggs? How long have they been doing IVF? Those are other questions to ask because typically the centers that have been more longstanding have been doing it the longest and they're, refining their recipes, right? They're over the course of time.
Yeah. Okay. So the live birth data is important.
Yeah, absolutely.
Because you can basically see that.
Right. Live birth rate and per embryo transfer.
Okay.
So you know that if a center has an average transfer of really 1 embryo versus a center that's transferring 2 embryos to achieve that same live birth rate is different.
Okay, got it. That's helpful. Okay, the next maybe myth, maybe not myth. Older eggs are bad eggs.
So what happens because we're born with those eggs as we get deeper into our reproductive years, they're hanging out, everything they're exposed to, the chromosomal backbone of those eggs starts to decline. And so what am I referring to, right? We really want the egg to be 23 chromosomes with an X in there, a single copy of each, and the sperm is 23 with an X or a Y. They come together to result in a 46XX or XY embryo. That backbone is number one, to a healthy pregnancy. And as our eggs age, there's higher chances of there being extra and missing chromosomes. So that's really what we're referring to. It does also happen with sperm. For men after the age of 50, the chromosomal health can start to decline, but it's a much more age has a much more gradual impact in sperm. For us, it really, you see it in the IVF stats, under, 37 and under IVF cycles at top centers have over a 50% chance of giving a baby, resulting in a baby. But 38 onwards, it's less, maybe 40%. So you really see that just general population kind of 38 onward across the board, it just gets more challenging because of that.
Yeah. The last myth. If you are stressed during your IVF cycle, it will fail.
Okay, so that's so we live in New York.
How can you not be stressed
we live
during
in New York.
an IVF
it's
cycle?
Stressful, right?
Or anybody anywhere.
It's stressful, right? The cycle is stressful, right? There's no way around that. It's going to be stressful. But there are things you could do to reduce that stress, have a support system. family, friends, actual mental health therapists who train specifically in this area who are there to support you, the team at your center, the nurses, the doctors, the medical assistants, right? Get extra rest, take care of yourself during the cycle, eat well. Extreme stress where you're not sleeping well, you're not eating well, trauma at home, trauma at work, those are tough times to do a cycle. So if you have a choice, I wouldn't cycle during trauma.
Sure.
Maybe sometimes you don't have a choice and you have to cycle then, but I think for the most part, it's unavoidable. Stress is unavoidable. So just try to, like I said, eat well, hydrate, sleep well, try to combat it that way.
Yeah. I guess this is actually like a positive story that there are a lot of success stories from IVF, and every single person who goes through this is so stressed out. And so extreme stress, yeah, you want to avoid, but you can be stressed and it can work.
Absolutely.
And it does work.
Right, because everyone's stressed.
Everyone's stressed. Yeah. And so that can actually be a really positive takeaway, that it's normal to have a lot of feelings going through something like this. And just because you're having those feelings doesn't mean that it's not going to work.
Exactly.
Right? You don't have to micromanage the stress, right? You can do things to help
yourself. Can't stress about stress.
You can't stress about stress. Yeah, that I think is the good takeaway. Okay, the last is not a myth question. I just want to end on asking you, what do you wish that every patient knew, walking into CCRM, the first time you meet them? What do you wish they knew?
Right. I feel like, because I'm on the other side of a lot of this, even in my personal life where I am in my age, what I would say is, go to a doctor, provider that you feel comfortable with. It's an open dialogue. It's a relationship we have together, right?
Mm-hmm.
I'm not just telling you what to do. You're also giving me feedback and clues as to how I could help you, right? So I really do think it's a partnership that you're going to have with your doctor and the team, and lean on them, and see them as a support. And if you don't feel you have that relationship, then I feel like probably find a different provider, because you really need that there to be in it for the long term, right? It's not even a marathon. This is an ultra marathon, right? It's not like you're done. It's 26.2 miles. It's a lot of times it could be 100 miles, right? It's you think you're done and it's not. And so, and you don't want to give up, right? That's what you need. You need that resilience and that grit, and you will be on the other side of it. You will be, getting to the very end of it. It works.
It works.
That's what I want to tell people. It does work,
yeah.
But it's a process and it's a journey, and there's a lot of steps to it, and there's a lot of curveballs sometimes too.
Yes, there are. Well, thank you. That was extremely insightful, not only educational, but I love when I can talk to an expert and they get to the real emotional, meaty level of the topic. And I just appreciate you being open to having that kind of conversation, because this is a super sensitive topic and people have tons of different opinions, and we're going to get so many crazy comments on this episode of people being like, you shouldn't even do IVF.
No,
but you know what? If you want a baby and you are struggling with fertility, you should move forward down this path. It doesn't matter what people on the internet think.
Yeah.
But before we end today, everybody, a couple of regular housekeeping items. So as I'm recording episodes, I'm really looking to learn from you and build a community here. So I am going to be asking you questions, seeking out your opinions and advice on Instagram and TikTok. I already did that for this episode. And I'm going to bring that content back to the show. So please follow me at Bosworth if you haven't. You can subscribe to the Tell Me I'm a Good Mom podcast wherever you are already listening. And you can watch complete video episodes of the show on my YouTube page at Bosworth. So that is it for today's episode of Tell Me I'm a Good Mom. Thank you to Dr. Talebian for coming onto the show and making time for us. And if somebody hasn't told you already today, I will. You are a good mom.